So good evening, everyone. Thank you very much for joining our Fireside Chat number 198. Today we have Professor Yazied Chothia, who is going to take us through the emergency management of hyperkalemia, a South African perspective. But before I hand over the mic to him, I'd just like to introduce the audience to the speaker. So Prof. Chothia is head of nephrology at Stellenbosch University and Tygerberg Hospital in Cape Town, South Africa. He has extensive experience with clinical training of undergraduate and postgraduate medical students and has supervised many postgraduate research projects, both MMed and MPhil. Nationally, he is an examiner for the Fellowship of the College of Physicians and an examiner and a convener for the Certificate of Nephrology. Prof. Chothia's passion for teaching was recognized when he received an award from Stellenbosch University for the bedside teaching of undergraduate students. Prof. Chothia is an is an active researcher and has published in local and international journals. One of his publications, a report on randomized trial of novel treatment for hyperkalemia, which I'm sure we're going to hear more of in today's talk, has garnered many citations, which has led to his PhD on improving the emergency management of hyperkalemia. He has presented his work at national and international meetings, including ASN's Kidney Week, the World Congress of Nephrology, and the Congress of the African Association of Nephrology. Nationally, he is an executive committee member of the South African Nephrology Society, and internationally, a member of the African Association of Nephrology Research and Ethics Committee. Prof. Chothia has recently been certified as a mentor by the International Society of Nephrology and is associate editor with African Journal of Nephrology and PLOS ONE. Regarding community interaction, he is involved in raising funds for patients with kidney failure to broaden access to kidney replacement therapy, and recently teamed up with Gift of the Givers to support patients with bridging dialysis. He is a regular guest speaker for the community radio stations and is involved in health education and promotion at local running club. So with that, Prof, the mic is yours. Thank you.
Thank you, Mazar, for that very long introduction. I think I'm going to shorten it next time. So yes, I'm just going to share my screen quickly. So thank you to Mazar for inviting me to give this talk. One of my, as you heard, it was the topic of my PhD a few years ago, and I continue to do research on this topic, and you will see some of our latest outputs that regarding hyperkalemia from our center. So I'll get straight into it. So hyperkalemia is a common condition, and I'm sure you've all come across this on the daily basis, and of course is associated with life-threatening complications, in particular cardiac arrhythmias, as well as muscle weakness and particularly respiratory muscle weakness, which may result in mechanical ventilation. So it is a very important the prevalence and incidence of hyperkalemia. So we were involved in this paper a few years ago during COVID, in fact, and we set out to perform a systematic review on the prevalence and incidence of hyperkalemia in all in patients who were either hospitalized or not, and we found that the overall prevalence was around 6.3%, and the incidence was about 2.8 cases per 100 person years. Now, what was very interesting in this systematic review was the high prevalence of hyperkalemia in Africa. As you can see there, it was around 22%. Now, the reason for that high percentage is actually there were very few research papers identified from Africa. If I remember correctly, I think we only identified around 3 papers. And of those 3 papers, it was all convenience sampling. So it was mainly patients who were with end-stage kidney disease, who were on dialysis, and it was prevalent studies of hyperkalemia in dialysis patients, or there were a few patients with acute kidney injury who developed hyperkalemia as a consequence. So because of the convenience sampling, we concluded that this was likely an overestimate of the prevalence of hyperkalemia from Africa. So there really is a paucity of data regarding hyperkalemia from Africa. So just to show you the studies, this is the pie chart of the number of studies from all around the world. And you can see 90% of the papers that we identified were actually just from 3 continents. And it doesn't show here, but we had about 9 papers from Africa. And regarding the comorbidities, I really just want to point out to you the risk factors that are associated with the highest prevalence of hyperkalemia. And as you can see here, the most common are really patients with kidney disease. Since potassium is really eliminated, 90% of the potassium we consume is renally eliminated. It's not surprising that patients with kidney disease would have the highest prevalence. So it's really a condition of kidney disease. And we also looked at the use of renin-angiotensin-aldosterone system inhibitors. And overall, it was around 5.8% for any renin-angiotensin-aldosterone system inhibitors. But the highest was when it was a combination of either an ACE or an ARB along with spironolactone or any other mineralocorticoid receptor antagonist, where it was nearly 15% of patients. And I'm sure you've come across this in your own practice. So I performed as part of my PhD, we looked at the hyperkalemia in our hospital, Tygerberg Hospital, which is a tertiary hospital. It has 1,300 beds. And we were interested in the prevalence and incidence of hyperkalemia in our center. And we identified just under 2,000 cases of hyperkalemia, excluding transplant and dialysis patients. And we found a prevalence of around 3.7%. So not too high, but that taken into account, it was the number of admissions we see per annum is around 50,000 admissions at our hospital. What was also interesting in our paper is other continents, other countries around the world really report on hyperkalemia in HIV patients. And this was one of the big outcomes. We wanted to know what is the prevalence of hyperkalemia in our HIV population. In studies that where they report on hyperkalemia prevalence, for example, in UpToDate, they overestimate the prevalence of hyperkalemia, where they include HIV patients with conditions such as Addison's disease, and report prevalence rates of hyperkalemia as high as between 30 and 50%. So again, because of convenience sampling, the prevalence again were overestimates. So we found that in our HIV population that were hospitalized during this 1-year period, the prevalence was 14%. Now the makeup of the patients was slightly different to the non-HIV patients. They were younger, they were predominantly female, they had less non-communicable diseases such as diabetes and hypertension and cardiovascular disease, and they were less frequently prescribed renin-angiotensin-aldosterone system inhibitors. And not surprisingly, a lot of patients were prescribed Bactrim, which contains trimethoprim. And this was mainly in patients who had AIDS-defining malignancies. So a lot of them had Kaposi sarcoma, lymphoma, cervical carcinoma, and so forth, and were using trimethoprim as part of a prophylaxis. There were quite a few patients as well with PCP who received treatment for PCP. The acute kidney injury was much more severe relative to the non-HIV patients who had hyperkalemia. But of great concern was also the fact that the mortality rate between these patients, HIV patients and the non-HIV patients, there was no difference. Keeping in mind that this is a younger population of patients who are dying due to other conditions other than the hyperkalemia, of course. We only reported on all-cause mortality. We didn't report on hyperkalemia-specific mortality. So this is just to show you, this is a regression analysis of in-hospital death versus the potassium concentration. And as we can see, there is as the potassium concentration rose, and we defined hyperkalemia as a potassium of 5.5, hence it starts around that value of 5.5 and goes up to, and the mortality rose to nearly 60%. Now, at the lowest value of 5.5, the mortality was around 25%. So at its lowest value, the mortality is quite high for patients who are for patients with hyperkalemia. And this was a multi-regression analysis plot. So we adjusted for all of these factors, age, sex, HIV, and so forth. And despite adjusting for all of these other covariates, the mortality was very high. So the all-cause mortality associated with hyperkalemia, even after adjusting for multiple covariates, is high. Now, this is data that we just recently completed, and in fact, as I can show you there, it's currently under review. We were interested in all-cause mortality of hyperkalemia in hospitalized adults, and we performed a scoping review of studies over the last 20 years. And it was roughly the overall estimate of mortality was nearly 25%. So 1 out of every 4 patients who have hyperkalemia, the all-cause mortality rate is very, very high. And what we found was that the main comorbidity associated with hyperkalemia that had the highest mortality rate were patients with acute kidney injury. So I don't think it is the hyperkalemia per se that is the cause of mortality in these patients. I think it is the cause of the acute kidney injury in the first place that really increases, that is really the result of mortality rather than the hyperkalemia itself. Now I'm going to just shift over to diagnostics of hyperkalemia, and here we're going to focus on the ECG and blood gas analysis for diagnosing hyperkalemia. So we recently published this paper in our local journal in South Africa, where we looked at the prevalence of ECG changes in patients who had hyperkalemia, and we found a prevalence of around 55%. So roughly 1 out of every, just a little over 1 out of every 2 patients who are hyperkalemic had some form of ECG changes. And we found a weak to moderate positive correlation between the potassium concentration and the number of ECG changes. So these are all cumulative ECG changes, as you can see here, and this would be, for example, tinted T waves, flattening of the P waves, PR interval prolongation, QRS widening, and sine waves. So none of the patients in this study actually we didn't identify any patients with ventricular tachycardia or ventricular fibrillation. And also an interesting finding was that in patients who had hyperkalemia but with no ECG changes compared to patients with hyperkalemia with ECG changes, there was absolutely no difference in mortality between the 2 groups. These were the common abnormalities that we identified on the ECGs. Interestingly, most studies report peaked T waves as the most common finding, but in our study, we identified abnormalities of the P wave as the more frequent abnormality, followed by peak T waves. And these P wave abnormalities were either flattening or disappearance of the P waves. And for some reason, and nobody really knows why, but during hyperkalemia, it seems to be that the atria are more have a higher predilection to the effects of hyperkalemia compared to that of the ventricles. Now, regarding the blood gas, we also performed this prospective study where we did phlebotomy in patients who had hyperkalemia, and we did simultaneous blood gas potassiums and a lab potassium. And we were interested in what is the correlation between the blood gas compared to the lab. And this is of importance because one would like to know the potassium concentration as quickly as possible and know that we can rely on the potassium on the blood gas so that we can institute treatment sooner. And this is what we found. We found that the blood gas tended to the potassium on the blood gas tended to be slightly lower relative to the lab potassium concentration by a mean bias of approximately 0.4 millimoles per liter. So in other words, if the blood gas potassium is 5.5 millimoles per liter, then in the lab it would be 5.9 millimoles per liter. So you can add 0.4, and you can see here over the potassium range, we again define hyperkalemia as potassium of more than 5.5, and you can see the mean bias remained relatively stable across the full range of hyperkalemia. Just to note that lab potassiums will always be slightly higher than a blood gas potassium for the following reasons. A blood gas potassium is performed on whole blood. In other words, it has to be anticoagulated. We used calcium citrate sprayed syringes when we performed the blood gas. So there isn't clotting occurring. Whereas with the lab potassium, the sample must first stand for about 30 minutes prior to being processed in the machine. And that standing for 30 minutes results in platelets. When it clots, it actually releases potassium into the serum, which is what we test when we send blood samples to the lab for chemistry. So a lab potassium will always have a slightly higher potassium concentration relative to a blood gas. So in our institution now, we simply do a blood gas potassium, and we simply add 0.4 millimoles per liter to the value on the blood gas to give us an estimate of what the lab potassium would be. Then just to go back, I just want to mention one other thing here, because the following slides that follow from here this is important to mention, that when we performed the lab potassium samples, it was done under proper phlebotomy technique. In other words, we didn't ask patients to fist clench. We didn't tap on the vein to make it stand out more. And we did apply tourniquet, but at the time of aspiration into the syringe, the tourniquet was removed. So it was done under proper phlebotomy technique. So this year we published this paper with Florentius Ndinya from Kenya, and we were interested in the prevalence and outcome of adults hospitalized with unexplained hyperkalemia. So unexplained hyperkalemia we defined as a potassium of more than 5.5 in the absence of kidney disease, drugs interfering with renal potassium elimination, patient who had rhabdomyolysis or tumor lysis syndrome. So we were interested in what is the prevalence and outcome of unexplained hyperkalemia. And we found a prevalence of roughly 8%. Now, we suspect that this prevalence of 8% is an underestimate of unexplained hyperkalemia, simply because of all our exclusion criteria here. But also, a study was performed in a urology outpatient clinic in patients who had stage 5 and stage 4 chronic kidney disease. And what they found was that prior to educating phlebotomists on proper phlebotomy technique, the prevalence of hyperkalemia in this clinic was roughly 16%. And after they trained the nurses or the phlebotomists on proper phlebotomy technique, the prevalence decreased to 3%. So we suspect that this, because we excluded all other causes of possible true hyperkalemia, that the prevalence of hyperkalemia, of unexplained hyperkalemia, this is an underestimate and maybe quite higher than what we think. And just to show you again, we performed a bland Altman plot where we compared the blood gas potassium to the lab potassium. And this time you can see that the mean bias was much higher. You can see it was plus 1.3 millimoles per liter. So what we are trying to, when the difference between a blood gas potassium and a lab potassium, if the difference between, or the mean bias between the two is more than 0.3 or 0.4 millimoles per liter, you're actually dealing with pseudo hyperkalemia. And that is really what unexplained hyperkalemia is. It is likely pseudo hyperkalemia. And we found a relationship between the unexplained hyperkalemia and hematological conditions. So these were actually 4 or 5 patients with hematological malignancies, and they all had hyperleukocytosis. So they all had white cell counts in excess of 100. And this is a classic cause for so-called pseudo hyperkalemia. And when we looked at our multivariate regression plot again, as I showed you previously, but this time in patients with unexplained hyperkalemia, and also adjusted for various covariates, as I'm showing there, you can see the mortality rate at 5.5 in hospital death was nearly 0%. And it only rose to just over 0.5% at the highest range of potassium concentration. So again, the mortality rate for unexplained hyperkalemia is very low, and we think this is actually just spurious hyperkalemia. It is not true hyperkalemia, it's actually pseudo hyperkalemia. Okay, so I'm just going to shift now to management and the management principles of the emergency management of hyperkalemia. And really it's 4 things. First, it is cardioprotection, shifting potassium into cells, removing potassium from the body, and removing sources of potassium. I'm not going to touch on every single one of these. I'm just going to mention a few as we move on. So I'm going to start off with insulin and dextrose, which was one of the focus of my PhD. So just to remind everyone about how insulin actually shifts potassium into cells. So imagine this little green triangle over here is an insulin molecule. And when it binds to its insulin receptor, it activates this channel called the sodium hydrogen ion exchanger, and it exchanges 1 sodium for 1 hydrogen in an electroneutral fashion. However, as the sodium concentration rises inside cells, cells don't like high sodium concentrations inside of them. So this high sodium concentration activates the sodium potassium ATPase pump, which pumps 3 sodiums in exchange for 2 potassiums. And this is how insulin actually shifts potassium intracellularly and specifically into muscle tissue. This receptor on this side here is a beta-2 receptor, and the beta-2 receptor, when salbutamol is administered, it directly stimulates the sodium potassium ATPase pump. However, the effect of salbutamol in shifting potassium is not as predictable as that of insulin. And in about 1/3 of patients, the decrease in the potassium concentration is less than 0.5 millimole per liter. So this is the randomized control trial that Mazhar mentioned when he introduced me as a speaker earlier. And this was actually also my very first publication as a researcher. So we performed this study where we either administered intravenous glucose along with insulin to end-stage kidney disease patients who had hyperkalemia, or they were randomized to a glucose-only bolus, intravenous bolus of therapy. And just to note that in this study, we excluded diabetic patients because the theory was that if we could increase the serum glucose concentration, that this would stimulate endogenous pancreatic insulin production, which would then shift potassium intracellularly. And we wanted to compare the efficacy between giving glucose only versus giving glucose along with insulin. We wanted to know which one is superior. Sorry, just to go back, just to point out some of the co-authors, Professor Razin Davids, who was my predecessor as head of nephrology at our unit. He's retired now. He was my supervisor on my PhD. And then many of you won't know, but Mitch Halperin, he's probably, as far as I'm concerned, the world expert on acid-base and electrolyte abnormalities. And he actually lives in Toronto. And Prof. Davids actually went to visit him recently because he performed a fellowship there for 1 year with Mitch Halperin. So this is what we found in terms of the reduction in the potassium concentration when we use glucose only versus glucose plus insulin. So the red dotted line is the patients who received a glucose only bolus compared to those who received an insulin bolus, insulin and glucose. And in fact, we found that in the glucose only bolus, there was roughly a 0.5 millimole decrease in the potassium concentration. However, the combination of insulin and glucose was superior, and the decrease was nearly 1 millimole per liter. In fact, it was 0.8 millimoles per liter. But I just want to make this point here, is that you can predict that when you give 10 units of insulin, that at 1 hour, the potassium concentration would have decreased by roughly 1 millimole per liter at 1 hour. Then Kamal here, Kamal is Kamal. He is also one of the world experts on electrolyte and acid-base abnormalities, and he also was actually the head of nephrology in Toronto, in the same hospital where Mitch Halperin worked. And in fact, the two of them have published many papers and textbooks together, including papers in the New England Journal of Medicine. So they also went out, Kamal and Xavier, they went out and performed the systematic review. And they wanted to know what is the optimal dose and method of administration of IV insulin in the emergency management of hyperkalemia. So they identified roughly 11 studies. And most of the studies, as you can see here, were retrospective, or they were non-experimental, non-randomized studies. And the risk of bias for most of the studies was either serious or critical. And also what I want to point out here is the number of patients in each study. They were very small. So the use of insulin and glucose is actually based on these studies. There were 3 randomized controlled trials. My one was included in this systematic review. And as you can see, my paper was the only paper that had the low risk of bias. All the other papers included had very high risk of bias in the systematic review. And I've just got a summary here of the studies where they compared bolus administration of insulin compared to continuous infusion. And continuous infusion was defined as over a 15-minute to up to 60-minute infusion period. And they were roughly split in half, 5 and 6 studies. In the bolus, they received 10 units versus the insulin infusion, continuous infusion, up to 20 units. And the dose of glucose was similar. It was roughly 30 grams. But of interest here is the hypoglycemia rates. It seemed to be that the hypoglycemia rates were much low, well, was halved in patients where they used a continuous infusion compared to the bolus administration. So this is really the feared adverse effect of administering insulin when using when being used to treat hyperkalemia. Just in my randomized control trial, we had a hypoglycemia rate of roughly 20%. And just to note that unlike this study where they used the average of 33 grams or 30 grams, in our randomized control trial, we used 50 grams of glucose. So even increasing the amount of glucose, we still had a hypoglycemia rate of roughly 20%. And they concluded in their study that there's no difference in efficacy between either using bolus or continuous infusion to manage acute hyperkalemia. So again, as part of my research, we went out and performed a scoping review looking at hypoglycemia as a side effect of insulin therapy when treating hyperkalemia in hospitalized patients. And here we found that the overall rate of hypoglycemia was roughly 17%, which is very high. And of concern is that many physicians and doctors don't consider the hypoglycemia that occurs when giving patients insulin. We also found that in terms of the prevalence of severe hypoglycemia, it was higher when higher doses of insulin were administered. That was statistically significant there. And it was again lower when a continuous infusion was given rather than bolus administration. And when we looked at all the studies included in the scoping review that we performed, we also looked at whether regression analyses were performed in these studies, and we simply counted the number of covariates that were or predictors of hypoglycemia in those studies. So the most important predictor of hypoglycemic events was actually the pre-treatment blood glucose concentration. And essentially, we found that if the glucose concentration was under 10 millimoles per liter, that the risk of hypoglycemia when using insulin to manage hyperkalemia was highest. So we must look at the patient's glucose concentration pre-treatment before we consider when we consider the risk of hypoglycemia later on. And this is the reason I think lots of doctors don't consider the hypoglycemia that occurs when using insulin. In our study, we found that it occurs roughly 2 hours after you've given your insulin therapy. So, and most guidelines recommend that hypoglycemia should be looked for up until 6 hours after administering insulin therapy for the treatment of hyperkalemia. But the peak incidence seems to be at around 2 hours. And in my opinion, in busy casualties or in busy emergency departments, when nurses are short and doctors are overwhelmed with patients, I recommend that we at least monitor for up to 3 hours post-insulin administration for hypoglycemia. And this was a survey that I performed in specialists from South Africa, but also internationally, we were interested in how many of them considered hypoglycemia or tested the sugar post-insulin administration. And you can see that as time went by, only 30% of specialists, these were nephrologists, critical care specialists, emergency medicine specialists, and so on, only 30% were still measuring the sugar at 2 hours when the peak in the prevalence of hypoglycemia occurs. Okay, I'm going to move away from insulin and dextrose and then just focus on potassium binding resins, and in particular, I'm only going to focus on K-oxalates. In South Africa, we only have access to sodium polystyrene sulfonate as a potassium resin. The more novel binders such as patiromer and sodium zirconium cyclosilicate is actually still not registered in South Africa for use, but I'm hearing that it may become available in the near future. So here was an old study performed in 1961, published in the New England Journal of Medicine, where they compared the use of a resin with sorbitol versus sorbitol alone, so an anosmotic laxative. And what was interesting in this small study, I think there was only 5 or 6 patients in the study, but on day 5, the potassium concentration reached the same value whether sorbitol, a laxative, was used alone or whether it was given in combination with sodium polystyrene sulfonate. So I was interested in, can we use laxatives alone rather than giving resins, sodium polystyrene sulfonate as therapy, because there is this risk of colonic necrosis that was added around 2010 by the FDA. There was a higher association of colonic necrosis in patients who received K-oxalate. And in fact, the FDA then added this black box warning, warning against this very rare side effect. This was also another case of hyperkalemia that was treated with the routine things, insulin and dextrose, sodium bicarbonate, Lasix, and even patiromer. And then with time, as days went by, the potassium concentration just continued to rise, even after increasing the patiromer dose, as well as adding salbutamol nebulizations. And then only when they added the lactulose did the potassium concentration start to decrease. So there's more and more evidence showing that laxatives may be an important arsenal in the management of hyperkalemia. And it's thought to have this osmotic effect by stimulating the so-called BK channels, which just really stands for big potassium channels located in enterocytes. And the high flow of stool stimulates these BK channels, causing secretion of potassium into the lumen of the gastrointestinal tract, and of course then excreted in stool. Another benefit of these osmotic laxatives, especially in patients with acute kidney injury who have anuria or oliguria, is that it can assist with volume management as well if the patient is at risk of developing volume overload and pulmonary edema. So we performed this study, and it's currently under review with a journal, where we looked at it's a post hoc analysis of the study that we published looking at the prevalence and incidence of hyperkalemia. We then selected the patients who received treatment with K-oxalate or received treatment with laxatives alone. And we wanted to look at, were there differences in the potassium concentration at 24 hours and more than 24 hours up to 1 week post-administration. And what we found was, when we looked at absolute potassium concentrations, there was a difference in the potassium concentration at baseline. Patients who received the combination therapy, this group here, the combination group, their potassium concentrations were higher at baseline relative to patients who received K-oxalate alone, which was higher than patients who received a laxative alone, which was roughly 7 millimoles per liter here. However, when we looked at the potassium concentrations at the end of 24 hours, there was no difference in the potassium concentration at 24 hours, and there was also no difference in the potassium concentration between 2 to 7 days. In fact, the mean duration for the 2 to 7 day period was roughly day 4 for all three arms. So there was no difference in the absolute potassium concentrations at 24 hours or between 2 to 7 days. However, they did start off with a higher potassium concentration in the combination group. However, when we looked at the difference in the potassium concentration from baseline to 24 hours, there was, again, no difference in the potassium concentrations at 24 hours. However, there was a progressive larger difference in patients who received the combination therapy, and in fact, this was statistically significant when we compared the combination group to the laxative alone group. The difference between the two was much higher, and this was also confirmed when we looked at effect size using Cohen's d and a test. It also found that the difference between the combination group and the laxative alone group, that to be statistically significant and clinically significant. Well, this is just research that we just recently finished, and it is a scoping review looking at the efficacy and safety of the polystyrene sulfonates, and here we included calcium polystyrene sulfonate as well as sodium polystyrene sulfonate, okay, oxalate. And we were interested in how effective is it and how safe is it in the management of hyperkalemia in hospitalized patients. So here we found that there was a statistically significant decrease in the potassium concentration from baseline to follow-up. However, I must point out here that the potassium concentration at baseline was only around 5,8. In fact, most of the patients in the studies that we found, the average potassium was under 6 millimoles for the majority of the papers. And this is also similar to a systematic review where they found in 22 studies, most of the patients where oxalate was used for treatment, the potassium concentrations were under 6 millimoles per liter. And we were also interested in what is the effect of the reduction in the potassium concentration when we looked at the dose administered. And there was a moderate effect, as we can see here. The correlation coefficient was roughly 0.46, and there seemed to be at least a statistically significant decrease in the potassium concentration as the dose of the resin increased. When we looked at the gastrointestinal side effects, the most common side effect was that of constipation and nausea and vomiting. However, what was interesting here was that patients who received calcium polystyrene sulfonate, they had a higher prevalence of constipation as a side effect. And what I just want to point out here are all these rare side effects of colonic ulceration, necrosis, and so forth. These were very uncommon, and I think the colonic necrosis due to sodium polystyrene sulfonate, the association with that is overemphasized. Regarding the constipation here due to calcium polystyrene sulfonate, we speculate that the calcium in the drug itself may actually be the reason why these patients are developing constipation, because there are so-called calcium sensing receptors located in cells lining the gut, and these calcium sensing receptors, when stimulated by calcium, can actually reduces gastric and bowel motility. And this may be an important side effect to be cognizant of, because how effective your resins are in reducing your potassium concentration is really dependent on stool volume. If stool volume is not high enough, it doesn't matter how much potassium binds to the resin. If you're not going to increase the volume of stool excreted, then the actual amount of potassium excreted won't be very high. So constipation as a side effect of resins is something that one doesn't want to develop. And that is why in initial studies in the early 1950s and 1960s, they used to add sorbitol to the resin in order to increase stool volume. However, the addition of the sorbitol is thought to increase the delivery and concentration of the resins to the colon, where it may then cause colonic necrosis. And as I mentioned earlier, when the FDA added the black box warning to the use of K-exolate, there were some formulations where K-exolate was already mixed with sorbitol, and the concentration of sorbitol was roughly 70% sorbitol. So after the FDA released this black box warning, the amount of sorbitol was reduced to 35%. So it was halved in order to negate the bowel necrosis or colonic necrosis associated with resins. We also looked at metabolic side effects, and of note here is that hyponatremia and hypomagnesemia. Hypomagnesemia was the most common, interestingly, but hyponatremia only occurred in patients who used sodium polystyrene sulfonate, no surprise there, and hypocalcemia only occurred in patients who received sodium polystyrene sulfonate, whereas hypercalcemia was more common in patients who received calcium polystyrene sulfonate. So again, no surprise there since it's calcium-based. Just to note here that hypomagnesemia and hypocalcemia with sodium polystyrene sulfonate is also not surprising, because sodium polystyrene sulfonate, although it is used to exchange potassium for sodium, the polysulfonates actually have a higher affinity for divalent cations. So it has a predilection for binding to magnesium and calcium rather than binding to potassium in the gastrointestinal tract. And that is why these side effects, these electrolyte side effects are so common, because they tend to bind with higher affinity to these resins. So just to end off, I just want to make sure that you guys understand that hyperkalemia is common in adult patients, and it is associated with high all-cause in hospital mortality, and especially when acute kidney injury is associated with hyperkalemia in these patients. The mortality is particularly high in that group of patients. The ECG has poor diagnostic accuracy, as I showed you. It's like flipping a coin, nearly just over 50%. So you shouldn't rely on the ECG to make a diagnosis of hyperkalemia. We really should use the blood gas, and the blood gas can be used safely as long as you adjust for that negative bias, as I pointed out in our study, of 0.4 millimoles per liter, and also be sure that the sample is drawn correctly. We must consider pseudo-hyperkalemia, especially when there is no identifiable cause. In particular, in my hospital, I look for kidney disease, and I look for any renin-angiotensin-aldosterone system inhibitors. And if the patients are not using any if there's no kidney disease or disease, then I consider pseudo-hyperkalemia as the most likely cause of the hyperkalemia, and simply performing a blood gas or performing the phlebotomy technique properly will reduce the risk of pseudo-hyperkalemia. Insulin efficacy is similar regardless of whether it's given as an infusion or as a bolus dose. And in our unit, we just give a bolus dose. One of the things that can be done to reduce the risk of hypoglycemia is to test the patient's sugar prior to giving your insulin and dextrose. And especially in patients where the sugar is under 10 millimoles per liter, we give 100 moles of 50% dextrose, not 50 moles of 50% dextrose. And we administer the dextrose before administering the insulin. And this has been shown in some studies to reduce the risk of hypoglycemia when the dextrose is administered before the insulin is given. And very important to remember that hypoglycemia is common. Nearly 20% of patients, 1 out of every 5 patients, and it occurs long after you've forgotten that you've administered insulin to the patient for hyperkalemia. So it peaks at 2 hours, and as I said, although guidelines recommend that you should look for hypoglycemia up to 6 hours post-shifting, in busy units, emergency units, that is not always possible, and I recommend that you test for up to 3 hours post-administration. And as I've shown here, sodium or polystyrene sulfonates are effective in reducing the potassium concentration. It reduces it by roughly 1 millimole per liter, but shouldn't be used for the acute reduction of potassium. It just doesn't work. It's not very effective in the acute setting, i.e. in the first 24 hours, and it needs time to reduce the potassium concentration, as I've shown in our study. And the adverse effects may be one of the limiting factors when prescribing these drugs. In particular, as I've shown, stool volume is really the key when using these drugs. And if you can't get the stool volume to be high enough, you're not really going to get on top of the potassium using these drugs. In our institution at Tygerberg Hospital, we've moved away from using sodium polystyrene sulfonate, and I've been pushing laxatives alone for the management of hyperkalemia over the longer term. And we're quite aggressive with the dose that we recommend. We're using lactulose at the moment in our center. Thank you.
Thank you very much, Prof. As always, a very nice, concise, and easy to follow presentation. And I believe that most of the audience have benefited quite a bit from it. Before we go into questions from the audience, maybe if I can just ask you a couple. So you answered one of the questions that I wanted to ask towards the end in the key messages with regards to using the resins as acute treatment. So you did mention that that is something that you can't use in an acute setting. So that's fine. The other thing that I also wanted to ask is with regards to the publication that is under review now with the combined, sorbitol and the resins. I mean, there's no difference. And given that there is a higher risk of having colonic necrosis, and from my fellowship time, I remember that this was something that was always frowned upon. Is it something that we can consider, given that in this part of the world, we usually have more calcium-based resins compared to solute-based. So we have the calcium polystyrene phosphonate, okay, and that causes constipation according to the study that you presented. So is it something that we can use if a patient develops constipation, or should it not be used at all?
Mazhar, so like I said, the FDA actually didn't say you must stop using it completely. They just reduced the proportion of sorbitol in mixed with K-exolate, for example. So it used to be 70%, and they reduced it to 30%. That said, in our center we don't have this combination. So we usually have to administer it as an additional therapy. So right now I can't really, recommend the use of adding a laxative, because there is this theoretical risk, although of colonic necrosis, although, like I said, I think it is an way over emphasized risk. In fact, there was a huge retrospective study that included nearly 120,000 patients. and they wanted to know what is the absolute risk or the numbers needed to harm to cause one episode of colonic necrosis, and it was you needed to administer 1,300 to 1,300 patients to get one episode of colonic necrosis. And I just want to make this point. It is nobody has actually proven that these resins actually cause colonic necrosis. It is still an association. And they have done biopsies on the rectum or on the colon or the tissue that is cut out in these patients where they've removed necrotic colon, and they found these crystals, the polystyrene crystals deposited in the tissue. But and people are equating this to, oh, it's causing it because it's sitting in the tissue. I just want to point out here that we don't know whether the tissue was deposited there and caused the problem, or did this happen after the fact? So because it's so rare, in fact, the prevalence of colonic necrosis in that big study was 0.07%. So it's so rare, and I think it is overemphasized. And what I think really needs to be done for this study that we've done is really where we compare laxatives to the combination. It's hypothesis generating, and in fact, what I would like to do is a randomized control trial, where we actually randomize patients with similar baseline potassium concentrations to either arm and then see what the effect is, and whether we can abandon the polystyrene sulfonates completely and simply use laxatives alone.
Right. Thanks, Prof. One more question before we go to the audience. You did mention something about beta agonists as part of treatment of hyperkalemia, even though their effect is unreliable. Can you maybe just clarify on the dose that is to be used? Because you would get to emergency departments and they'll throw the kitchen sink to the patient and give everything. So you just want to make sure that the dose that is given for the beta agonists is actually what you want the effect
proper
to
dose. Yes, so the dose you must use is not the doses recommended for bronchospasm in your asthmatics or your COPDs. The dose recommended is 10 to 20 milligrams. So usually we would use 5 milligrams salbutamol nebulizations for bronchospasm. You need much higher doses for shifting potassium into cells. So you need to give between 10 up to 20 milligrams of salbutamol nebulizations. And that said, there was a Cochrane review looking at the emergency management of hyperkalemia. And in fact, the combination of insulin and salbutamol nebulizations was superior to insulin or salbutamol alone. And you can expect a decrease in the potassium concentration of roughly 1.5 millimoles per liter with the combination. Whereas I showed you, with insulin alone, it's roughly 1 millimole per liter. And with salbutamol alone, in about a third of patients, the effect is less than 0.5 millimole per liter. So the combination, I recommend the combination frequently in our setting. One must be cognizant of possible underlying cardiac disease, particularly ischemic heart disease, because you're increasing heart rate and there is an increased risk for arrhythmias because of the doses administered with salbutamol. So that's really the key.
Great. Thanks, Prof. Prof. Bhima, you can unmute and ask your question.
I have two questions for Yazied, but thank you so much for that wonderful presentation. That was really, really good. Okay. So the first one is a case that we have in the ward presently. It's actually a pediatric patient, but with hyperkalemia. It's an 11-month-old who presented with hemolytic uremic syndrome, was dialyzed, renal function improved, the platelet counts have normalized, not hemolyzing LDH normal. Everything's fine, but this patient had quite severe neurological involvements, and the neuros to control the dyskinetic movement and the convulsions, loaded with epilim and phenobarb, and then started the child on high doses of phenobarb and epilim. Of course, the liver function deteriorated, and then they changed it to Keppra and started reducing the phenobarb. The liver functions are improving, but patients' potassium levels began to climb and went up from a level of 4.4 right up to 6.4. So the patient was also hypertensive, so I started hydrochlorothiazide, hoping that will drop the potassium. Nothing much happened. I stopped all the ACE inhibition, any aldosterone, all the things that will likely raise the potassium.
Yes.
But the potassium still remains high. The neuros tell me that this drug doesn't cause, any of the drugs they are giving don't cause high potassium. So what will be the likely cause of this hyperkalemia in a patient like this? Because I'm really wondering what can be.
You tell me what. So the patient was having a dystonic movements or seizures or something like that. You mentioned
The combination of this, a combination of dystonic movement and seizures. So they gave, So they gave epilim and they gave high dose phenobarb loading doses.
Yes.
Continued the phenobarb and epilim, but because the liver function started deteriorating, they stopped the epilim, started reducing the phenobarb, and put the patient onto Keppra. I'll tell you the.
Do you know what
levetiracetam.
Levetiracetam, yes.
Yeah.
Okay. No, I'm not aware of any of those drugs causing hyperkalemia. Sometimes it's very rare for drugs to be potassium based. If sometimes the most drugs are sodium based. The salt added to the drug is sodium. So it's very uncommon for drugs to have potassium. There are certain penicillins, for example, that we use IV, where it may be potassium based, but those are very uncommon. In this case, have you checked the patient's CKs to look for rhabdomyolysis?
Yes, it's low. It's practically normalized. So we did the LDH and it's not hemolyzing. LDH has come down from the thousands down to about 300.
Yes. So I would also, because of this history of hemolytic uremic syndrome and possible, I hear that you say the hemolysis is reducing. You may want to also just make sure that this is not pseudo hyperkalemia.
We did. I did that because I was very cognizant. I told the medical officer, take the blood in front of me. So we removed the tourniquet and everything. You know what I mean?
Yes.
And we used.
And you did a blood gas as well? It's high on the blood gas as well?
Well, the blood gas was slightly lower than I gave you the serum. Yeah, but it was within range. It wasn't like
it wasn't more than the 0.3
millimole. Wasn't much.
Okay. Now then
blood gas came back on the latest one. The serum was a 5.6. Blood gas came back as 5.4. So it's not much different.
Okay. So Rajendra, I hear you. So it was under 6 on the blood gas. In other words,
after we started, I tried the hydrochlorothiazide and everything. So but what I'm saying is still high. 5.6 is still high for.
Yes. No. I hear you. Yes.
So
now,
I'm trying to work out what is this.
Yeah, unfortunately, and the patient isn't receiving propofol. The patient isn't receiving propofol.
No.
Okay.
Then one thing is that I checked the urine potassium, and it was quite high. It was like 63 or something because of the hydrochlorothiazide. You know what I mean? So
yes.
So it's definitely losing the potassium.
Yes.
But I don't understand why the serum potassium is still so high.
So that just tells me that the kidneys are responding appropriately to the hyperkalemia. And just for people, just for the audience to know, an appropriate renal response to hyperkalemia is to see a ratio of potassium to creatinine of more than 20. In other words, the kidneys excretes like 200 millimoles plus of potassium in the urine per day when there is hyperkalemia for an appropriate response. So in the absence of a kidney problem, you need to then either consider other things like a shift out of cells regenera, or looking for possible cell lysis, like due to necrotic tissue, or like I mentioned, rhabdomyolysis, or one of those other causes. So, but a shift out of cells is a, how can I say this? It is an acute thing. It happens acutely. The onset is acute, and the reversal is also acute. So it happens within hours and reverses within hours.
Yeah.
It sounds like this has been going on for days.
No, this is going on for days. This has gone on for now.
Yes.
It's five days.
Yes.
So
yes.
I read the literature on HUS, and one of the things that I'm just telling you what the discussion was on the paper was that when you get glomerular recovery, it is more rapid than tubular recovery. And sometimes tubular recovery lags behind, and therefore this may be the reason that but this have got an appropriate tubular response because the urine potassium is high.
No,
So
yes.
I had to rule that out as a possible cause. You know what I mean?
Yes.
So I'm still grappling why this patient has such high potassium.
Yes.
Anyway,
so
I'll give you feedback.
The fact that there's 60 millimoles, it tells me the
Yeah.
kidneys are not the cause.
Yeah.
There's some other thing.
Some other reason.
Yeah.
So my second question, sorry,
yes. Sorry, just before we finish, is the patient's not receiving any nasogastric tube feeds or foods?
No, it's on.
That has potassium.
It's on. The dietitian was consulted, put the patient on a low potassium diet and everything else.
Okay.
So despite all of that, all the normal thing that we do, we even get KXLA, by the way, and it's still high. See?
Still high.
So the only thing I didn't do was give lactulose, but I'm gonna start the lactulose tomorrow. Anyway, so
try the lactulose.
Try lactulose. So my second question is, sorry, I don't want to hog the floor,
no, that's fine.
Is that I'm still not understand why pharmacological administration of insulin will have a greater effect than endogenous insulin. If I eat a chocolate cake, you know what I mean? If I eat it, I mean, my endogenous insulin is going to kick in, and that should work. So is there any explanation for this? Because you said that giving insulin with dextrose is much more effective than just giving dextrose itself.
Correct, yes. So now there's a good reason for that.
Yeah.
So remember, when your pancreas secretes insulin, it secretes it into the portal vein. And roughly, for many, I don't think a lot of people know this, but the bioavailability of pancreatic insulin production is only 50%. So in other words, when the insulin goes through the portal vein through the liver actually metabolizes half of the insulin, and only 50% actually gains access to the systemic circulation. So that's one reason why the amount of insulin that goes into the systemic circulation is lower. But there's another reason. The effect of insulin, the amount of insulin you need for sugar control is compared to that for the kalemic effect, for shifting potassium into cells. The amount of insulin you need to shift potassium into cells is 5 times that of the glycemic effect. So normally your insulin levels are around 100 micro international units per liter. It needs to be 500 micro international units per liter to shift potassium into cells. So in other words, you need 5 times the amount of insulin to shift potassium. So therefore, the only way to get that amount of insulin into the systemic circulation is to give it intravenously. And the half-life of insulin is 5 minutes. So every 5 minutes, your insulin is dropping by half in the systemic circulation. Hormones generally have very short half-lives. That's why for most hormones like adrenaline, noradrenaline, dopamine, it has to be given as an infusion to have an effect, because the body has all kinds of mechanisms for metabolizing hormones.
Oh, great.
Right.
Thanks. Now let me learn something. Thank you.
Not a problem, Rajendra. Thanks for the questions.
Thanks, Prof. We have got quite a bit of questions, so if you don't mind hanging on for a bit longer.
Sure.
We have got Shiba Muyoka. If you can unmute and ask your question, your hand is up.
Thank you, Prof, for the wonderful
Yes.
presentation. I have just a short question. You said that ECG is very poor to diagnose the hyperkalemia, but sometimes when we take a sample to the lab, most of them you found like we can get a hyperkalemia due to just because the sample has been hemolyzed. How do you consider that in case we don't even rely on ECG?
So are you asking how, if the sample is hemolyzed, how do you rule out that there is hemolysis, or are you asking about in a patient who has a hemolyzed specimen, how do you rule out using an ECG that it's a hemolyzed specimen? Is that what you're asking?
Exact, Prof.
Okay. Okay, no, thanks for that question. So remember, when it is a hemolyzed specimen, in other words, it is a spurious event. It is something, in other words, it's an in vitro phenomenon. It's not an in vivo phenomenon. In other words, in the patient's blood, in the body, the potassium concentration is actually normal. However, in the lab, in the test tube, there is an abnormality that is detected for whatever lab related or pre-analytical problem that may have occurred. For example, the way we do phlebotomy technique. So you don't expect an ECG to be able to detect an in vitro problem. In other words, because in the patient itself, the potassium is actually normal, but in the lab, the potassium is abnormal. And the way to pick that up is, as I've mentioned earlier, you either do a blood gas, where you do it on whole blood, where it's not a hemolyzed specimen, and you will then find a big difference of more than 0.4 millimoles per liter difference between the lab and the blood gas. Or the lab itself will give you a so-called hemoglobin index. And the hemoglobin index is also it's also the hemolysis index. It will tell you whether there is significant hemolysis in the tube itself. Does that answer the question?
Yes, Prof. Thank you.
Okay.
All right. Thanks, Prof. Amar, I see you've got quite a couple of questions on the chat. Do you want to ask them verbally to Prof? Hello, Amar. Okay, I'm gonna ask the questions anyway. So Amar is a senior nephrologist in Tanzania, and he's asking, what is the optimal dosing and dosing strategy? Example, rapid versus slow infusion for insulin, typically 10 units or as 5 units in CKD patients, combined with dextrose to safely shift potassium intracellularly while minimizing hypoglycemia. I believe you had answered this question, but maybe just a repeat.
Fine, I'll answer it again, Mazhar. So no, good question. I didn't go into too much detail regarding that. And they have done studies, Amr, where they looked at 5 units of insulin compared to 10 units of insulin in patients with chronic kidney disease or acute kidney injury. And they actually found that 5 units was as effective as 10 units of insulin. So, and also reduced it by roughly 1 millimole per liter. And although equivocal, some studies showed a lower rate of hypoglycemia when 5 units of insulin was used in patients with abnormal kidney function compared to using 10 units. So yes, I actually do sometimes recommend that they must use 5 units of insulin along with 50 mils of dextrose to reduce the risk of hypoglycemia.
Thanks, Prof. A follow-up question from him also was, could point-of-care machines be calibrated or protocols be adapted, given that many clinicians trust their readings, but non-nephrologists especially may under or over-treat? I think it's about point-of-care machines in the use of potassiums, in the sense that everybody would want to use their own institutions.
I understand,
readings.
yes.
Yeah.
So the quick answer is everyone must actually do their own calibration to make sure that the machine that they're using and the lab, what the difference is. You will have to do your own method comparison studies. That our machine, for example, was the one that we had in the emergency unit, and there are various vials that we used for calibration. So it gets calibrated every time a new cartridge gets inserted into the machine. So we were happy that our machine, the quality and the output the accuracy was very good. So Ahmad makes a good point. Yes, you must actually do a formal, you don't have to do a study, but you can send a few samples of potassium and compare that to the lab potassium to make sure that the method is in fact comparable to each other. That said, most studies looking at the difference between lab and blood gas, the definition for pseudo hyperkalemia is 0.3 to 0.4. If the difference is more than that, you must consider pseudo. Okay, so that seems to be consistent regardless of the various lab methods being used or blood gases being used. That definition seems to be consistent across labs.
Okay, thanks, Prof. Another follow-up question from him. He says that how much does nutritional counseling impact hyperkalemia and CKD? And do you have any experience in using fludrocortisone in hyperkalemia management?
No, I do have, yes. So I didn't go into nutrition. I just want to say I have become personally less restrictive with my CKD patients with regards to diet. I just want to say that in patients with acute kidney injury, you should restrict potassium in the diet. But in stable CKD patients, I have become less restrictive. Even in my hemodialysis, chronic hemodialysis and peritoneal dialysis patients, I don't restrict the diet anymore for various reasons, mainly because of our patients can't afford to be selective in what they choose. You know, whatever lands up on the plate is what they're having for dinner that evening. But also, the pendulum seems to be swinging away from this potassium restriction in patients with CKD. So there are theoretical advantages to not restricting vegetables and fruits in patients with CKD. The first is the fiber in the food actually increases stool passage and stool excretion of potassium. That's the first. The second is because of the glucose content in fruits, the spike that one gets from insulin actually shifts potassium into cells. Second, because the fruits are alkali, it's an alkali load. The metabolic alkalosis actually also helps with shifting potassium intracellularly. So and also a very important factor is the bioavailability of potassium in fruits and vegetables is roughly 60%. But in ultra-processed foods, the bioavailability is between 80 and 90%. So when people eat fruits in its whole form, the bioavailability of potassium is actually reduced compared to when the fruits are juiced and the digestive tract doesn't have to metabolize the food. The fiber in the food actually lines the gut, slowing down the absorption of potassium. Just to let you know, I was involved recently in a commentary. It will come out in the next few weeks in Lancet Global Health, where a group of specialists around the world, potassium dietitians, nephrologists, cardiologists, we got together and we've written a commentary on low sodium salt substitutes, where we actually advocating for the use of potassium containing salts in patients with earlier stages of CKD because of the theoretical advantage of improved blood pressure control, because it's not sodium based, it's potassium based. And there's evidence to show that even the potassium in the diet may retard CKD progression directly on the kidney, but also by improved blood pressure control, it has that effect on reducing CKD progression. So the pendulum is slowly swinging away from restricting potassium. When I say potassium, I'm talking about in fruits and vegetables in particular. And this commentary now that will come out in the next few weeks in Lancet Global Health is specifically in patients where it's not fruits or vegetables, it is low sodium salt substitutes, but in earlier stages of CKD, because the bioavailability is still high because it's not in the fruit form. It's in a free form, if I can say it like that. So the absorption is higher.
And what about the fludrocortisone experience in hyperkalemia management?
So I only use fludrocortisone in patients where I suspect hyporeninemic hypoaldosteronism. So this is classically in patients with diabetic kidney disease. So they usually have hyperkalemia, a mild hyperkalemia of 5.6 maybe, 5.5 to 6 millimoles per liter, and a mild degree of metabolic acidosis. The bicarb is usually under 20, let's say it's around 17, 18 millimoles per liter. And when you look at the metabolic acidosis, it's a normal and iron gap metabolic acidosis. And classically in the diabetic who either if they've got hypertension, I don't use it because the fludrocortisone will worsen blood pressure control. However, if they are normotensive, then I use fludrocortisone. And I've used it a couple of times in a few patients with hyperkalemia and diabetic kidney disease with hyporeninemic hypoaldosteronism.
Thanks, Prof. Another question is, what is your personal hyperkalemia protocol in order? So, I mean, if you were to treat a patient with hyperkalemia, how would you treat them in that order?
So for me, it would be 5 to 10 units of insulin, rapid-acting insulin. I first administer the dextrose, 100 mils. As I mentioned earlier, in order to reduce the risk of hypoglycemia, I check the sugar before the time. In all patients with sugars under 10, I give more dextrose. And like I mentioned, 100 mils, which is 50 grams, not 25 grams of sugar. And it must be given as a bolus. So when I say a bolus, I mean the insulin should be pushed in with your hand. It shouldn't be hung up and you walk away. You should literally squeeze the bag like this. Okay. You should squeeze it in my randomized control trial. That's exactly what I did. I squeezed the insulin in a 50 ml bag of normal saline within 5 minutes. All the insulin was in, because it's all about getting that peak. You want that, as I mentioned to Prof. Beamer earlier, you want the insulin concentration must be 5 times greater than that needed for sugar reduction. So you need to reach the peak quickly. So you squeeze it in. And then after all of that's done, I repeat the sugar, the potassium concentration on a blood gas an hour later. And the expected drop should be around 1 millimole per liter. And I just want to make the point here that the term refractory hyperkalemia. I think there's a misunderstanding by many people what the term refractory hyperkalemia means. Refractory hyperkalemia, in my opinion, is not when somebody comes to me and says, can you please come and dialyze the patient because we shifted the patient 3 times. I want people to remember that the effect of insulin in shifting potassium is transient. It lasts between 4 to 6 hours. And then the potassium all leaks out of the cells again, and you're back to where you started. This is not refractory hyperkalemia, when it comes out again and you have to shift again for a second time or a third time. Refractory hyperkalemia is when you've shifted the patient and an hour later, the potassium is either at the same level where you were when you started or higher. It hasn't, in other words, it hasn't dropped by the 1 millimole that one expects. So after a single shift, you can already diagnose refractory hyperkalemia because it's refractory to treatment. It hasn't done what it was supposed to in that hour. In really severe cases, I do add salbutamol nebulizations as well. As I mentioned, that has been shown in a Cochrane systematic review to be the most effective management. And I do check the sugars hourly for up to 3 hours, specifically at the 2-hour mark. Patients may actually have asymptomatic hypoglycemia, whereas others may go all the way to having seizures and coma. So, and I've seen that multiple times, and it's people forgot that when the patient's having a seizure, they're wondering why the patient's having a seizure. And when you check the sugar, it's 1. So the checking of the sugar is very important, in my opinion.
Okay, Prof, I know we are quite above time. I'm not sure if you still have some time. We have quite a few questions, unfortunately, or rather fortunately. So some of them are repetitions, so I will not ask. We have one question from Dr. Mojo. He's a medical officer in the central part of Tanzania, and he is asking with regards to cardiac resuscitation, which usually is difficult in patients who have arrested because of hypokalemia. So what are the key life-saving steps, medications, or techniques that you can use for successful cardiac resuscitation in these patients?
Yeah, I don't know if what the advice I'm going to give is going to result in successful cardiac resuscitation. But yeah, the most important, and I didn't talk about it, remember I said the 4 principles of management and cardioprotection would be calcium salts. So in the past, we used to recommend that you give 10 moles of 10% over 10 minutes infusion. And if the ECG abnormalities persist, that you must repeat it again. And it's now the UK Kidney Association, the UKKA, they recently changed their guidelines to say don't give 10 moles, give 30 moles once off if there are obvious ECG changes. And the reason for the 30 moles is because calcium gluconates, the molar quantity of calcium in calcium gluconate is lower than that of calcium chloride. So the amount of calcium in calcium chloride is 3 times that of calcium gluconate. And there are studies, we don't have a lot of studies actually, but because of the higher calcium load in calcium chloride, it's thought theoretically to be more effective for cardioprotection when there are obvious ECG. So hence they said, don't waste time by first giving 10 mils and waiting and then giving another 10 mils and wait. Just give the 30 mils once off. And if the patient doesn't respond to that, you cut your losses and you need to institute other things, dialysis and so on. So that said, some also advocate for administering calcium frequently until the ECG changes correct. So you keep giving it, you keep giving calcium gluconate until the ECG changes respond. So the risk of giving such a lot of calcium is you must ensure that your intravenous line is in fact in the vein. So I would, if you're going to give that much calcium gluconate, I would say you probably need to administer it through a central line, because if there is extravasation of calcium, as you know, it is needed for vasoconstriction. It causes intense vasoconstriction in tissues and causes tissue necrosis. And we've had patients where this has happened, where they actually needed to go to theater for debridements and frequent debridements because of necrotic tissue. So that is the risk when you're administering that amount of calcium, is the tissue necrosis. But the key is really the calcium gluconate in the arrested patients. That is really the key, is the calcium gluconate.
Thanks, Prof. Another question is about using loop diuretics to manage hyperkalemia. What are your thoughts on that?
My quick answer is no. I don't think loop diuretics work for hyperkalemia. It's very simple for me. The reason is loop diuretics, specifically furosemide, it doesn't work long enough to actually induce to cause enough or significant potassium excretion in the urine. It's you know the name Lasix. I always teach this. Do you know where I always ask the registrars, where does the name Lasix comes from? It comes from last 6 hours. In other words, Lasix only works for 6 hours, and then it stops working, and the kidney is now just retaining sodium and so forth. So, and all the cases, or most of the cases that I've come across where the patients developed hypokalemia have been with thiazide or thiazide-like diuretics. And the reason is very simple. Thiazides work for longer. And that's why you developed hypokalemia and hyponatremia and those electrolyte abnormalities. It rarely occurs with Lasix in my experience. So I don't advise using Lasix to lower potassium. It does, unless you're giving it as an infusion. But even then, the patient needs to be passing urine. And we usually see this in patients with acute kidney injury who are oliguric or anuric. And if the patient's not making urine, you're not going to get rid of the potassium. So don't waste time with Lasix.
Thanks, Prof. I think there's another question about the beta agonists. The question here is, how do you give it, or what's the preferred method of giving it, oral versus nebulized?
So most of the studies are on nebulized salbutamol. So that's really the method that I would recommend is the nebulizations, not the oral administration.
Okay, follow-up question from the same member of the audience. Please comment on the management of hyperkalemia in Addison's disease.
So in Addison's disease, the steroids that we use actually helps with reducing the potassium concentration. So when you're giving patients large doses of hydrocortisone, in the kidney, in the cortical collecting duct of the kidney, they are in the basolateral membrane of principal cells. There's an enzyme called 11-beta hydroxysteroid dehydrogenase. And under physiological conditions, cortisol, which is a steroid, is converted into an inactive metabolite as it tries to cross the membrane to stimulate the cytosolic mineralocorticoid receptor. So it doesn't have an effect on the mineralocorticoid receptor. However, when we're giving large doses of steroids like hydrocortisone, 100 milligrams, then you saturate the effect of that enzyme in the basolateral membrane, and the excess steroids then gain access to the cytosol and stimulates the mineralocorticoid receptor, which increases potassium elimination. In fact, that's how the steroids work to improve blood pressure control as well, because it also stimulates sodium and water retention in patients with Addison's. And of course, thereafter, you will come with your more chronic oral steroids. I can't remember what it is that they use for medicines. But in the acute setting, the hydrocortisone is actually what helps for the potassium elimination by the kidney.
Thanks, Prof. One last question. Again, it's from a nephrologist from the central region of Tanzania, Alfred. He actually did his PhD with Prof. Naika in WITS. So yeah, he is asking about, he did his PhD in biomarkers. So first question is about biomarkers. Any novel biomarkers that can diagnose hyperkalemia earlier than the routinely used tests? And then second, he asks is, what is your take on novel potassium binders like sodium zirconium cytosilicate and patiromer as compared with the ones that we are doing currently? Do you have any ongoing studies? And with their introduction, is it possible to allow patients to stay on beneficial drugs like RAS inhibitors?
Yes, no, thanks for the first biomarker question. I don't know of any biomarker. Maybe he can, maybe he knows something that I don't. So, but if you're interested in the potassium, then just measure the potassium directly if that's what you're interested in. But of course, if there's something else, he must let me know. Regarding the novel binders, I've got absolutely no experience with novel binders because it's not available in South Africa, and therefore I'm actually not doing any research at the moment myself as a investigator-initiated research. There may still be studies being done by the pharmaceutical companies, clinical trials, but from me personally, I'm doing nothing. Regarding the question of, there are studies on its effectiveness in the acute setting. I know of a handful now where they've shown it to be as effective as K-Exolate in reducing the potassium concentration. Some have shown some have shown efficacy, whereas others have failed to show efficacy in terms of reducing. So it's still equivocal whether the novel binders can really be used in the acute setting for reducing the potassium concentration. In the original studies were published in the New England Journal, the patiromer, for example, after 1 year of treatment, reduced the potassium by 1 millimole per liter. Now that said, these drugs are very good for chronic control of potassium, where one wants to continue using renin-angiotensin-aldosterone system inhibitors. And I think that was the question that was asked. And we found in our study that we published on the epidemiological study on the prevalence of hyperkalemia, we found that in patients in hospital that continued to use RAS inhibitors despite having hyperkalemia, they actually had better survival in hospital compared to patients where the RAS inhibitors were discontinued. And we actually speculated that it wasn't the hyperkalemia that killed the patients in hospital. It was the primary indication for the RAS inhibitors in the first place that actually caused their death, which was likely cardiovascular disease, poorly controlled cardiovascular disease, heart failure, ischemic heart disease, myocardial infarctions, and so forth. And there's lots of studies coming out to show that discontinuing RAS inhibitors, despite hyperkalemia, is associated with poorer outcomes. And that is why, and that is really how they're punting the novel binders. They're actually using that fact to show that if you continue it, your hospitalization rates are better, your survival rates are better, and so forth. But it's very expensive.
No, we don't have them here either. Maybe in the future they may come through, but right now we just have the resins and the laxatives. One final question. What is the definitive first-line management of hyperkalemia caused by digitalis toxicity in a patient with acute cardiac arrhythmia?
Wow. So the potassium, the management of the hyperkalemia, I would manage it the way we routinely do it, as I mentioned, insulin and so forth. I don't know when last I've seen a patient using digitalis, a digoxin.
We still use it.
Is it? Okay. So I from my experience as a registrar, when we were still using the digoxin, yes, hyperkalemia is one of the complications because of the way it works on the sodium potassium ATPase pump. And we back then we used to manage it the way we routinely manage these patients with insulin and dextrose, and back then we used to add K-Exolate and so on. I've never used the anti-fab IV to bind the digitalis. We've never had to use that. Of course, you don't want to shock the patient if there's an arrhythmia, because when a patient uses digitalis, it is actually pro-arrhythmogenic as well. So we never did. We had to either dialyze the patient then, or get hold of that what's it called? The anti-fab immunoglobulin. I can't remember what it's called. It's something that binds the digoxin in blood to lower the levels. Anti-dig fab or something. I can't remember. Yes.
All right. No, I think that is something that probably we need to just be wary of, and probably use it as sparingly as possible, just to make sure that we don't run into trouble of that. I think, Prof, thank you very much for staying over time. As you can see, quite a bit of interactions, and I see still their hands are coming up, but I think we are quite above time, so I think we'll end here. Just a comment from Dr. Lloyd. He does say that Dr. Lloyd did his fellowship in Toronto, did his transplant fellowship there, and he does mention that while he was there, Kamal and Mitch were amazing teachers at the fellowship at St. Mike's, and both masters in fluid and electrolytes. Thank you for mentioning them. TTKG was something that I learned from Dr. Kamal. Yes, for the first time, for the first time we heard over 200 attendees in the Fireside. So thank you very much for that. As I said, Prof, it is an interesting topic, and people look forward to listening to you. So thank you very much for coming on. Thank you very much for being patient and taking all the questions. And we'll make a plan for the ISN ambassador thing. I'll get in touch with you soon.
Sure, no problem, Azad. Let's work on that.
Sure.
Thank you, everyone.
Thanks, Yazid.